Thank you. And it is great to be here and for this event. Really impressive turnout. This unbelievable venue that you all have here. I mean, I'm from San Francisco. It's a beautiful place. We don't actually have places that look quite like this. So I'm very pleased. I'm also particularly pleased to be able to join Dr. Duquesne in this day, and all of you. I live mostly on the purchasing side of healthcare, working with the employers and insurers and all that, trying to structure better incentives. But at the end of the day, we're only going to get the healthcare system we want if the physicians embrace value and take the leadership in this, because for really two reasons. The doctors make most of the real-world decisions in healthcare, which test, which drug, which procedure. Those are mostly doctor decisions. And secondly, at the end of the day, the patients are going to go with the doctor. If they have to choose, who do I trust? Is it going to be the hospital? Is it going to be the employer? Is it going to be the insurer? Is it going to be the professor? They'll say, I'm going with my doctor. And so the doctors need to embrace it, and physician thought leaders like Tony are really important. It's really talking with the rank and file practicing doctors and surgeons is really important. So what I want to do with you today is talk about the issue about pricing. And I want to talk about at least the importance of pricing, and then three dimensions of that. We talk a lot about price transparency. We're all in favor of price transparency. But what are you going to get from that by itself? So we're going to talk about bundle pricing and reference pricing. What are they? How they fit together. And I'll present you a little bit of data from experiences out on the West Coast, some large employers out there who put in reference pricing and the effect that has on consumer behavior and then on the cost experienced by the employer. We're all trying to find that balance in healthcare between we want a consumer-driven healthcare system where the individual makes as many choices as possible for him or herself. On the other hand, those choices have to be meaningful, they have to be informed choices, and we don't want this to come back and bite us some other way. So that's what I would call responsible choice. Implications of that. I just added a couple of different slides just to get us going this morning. Sticking with Tony's procedure, knee replacement surgery. Okay, this is I think it's the highest volume procedure that Medicare pays for. All right, this is the variation in rates of use. So it's all of this, or 10, this is Medicare data, tenfold variation in the rate of use. And go, wow, why? And what it is, it's not the rate of use of, the rate of underlying arthritis does not vary. This has been driven heavily by patient preferences. Different patients, do they want surgery? Do they want non-surgical treatments? Here's another one. These are California data. This is the price variation. Each one of these little dots or lines is an average for the hospital. And this is the prices charged before reference pricing. I'll get back to this later. For the same procedure, this is one of these, the light blue is the hip and the dark blue is the knee replacement surgery. So it ranged from about $20,000 to about $120,000 for the same procedure. This is data come from the California Public Employees Retirement System. They have 1.3 million people covered by health insurance, California, state, municipalities, and all that. They looked at this. This was right at the middle of the economic recession, when California was basically bankrupt, right? And they look at this and they say, "You can't do this. You can't do it." There's no quality. There's no evidence, by the way, that high price was associated with high quality or anything. These were just variation. This got going. And then if you look at this, my last little sort of intro slide. What is a price in healthcare? This is a procedure. This is knee replacement, and so this is where the costs are. You see that most of the costs are actually in the inpatient stay. But even that, part of that is the physician side, and anesthesia and all that. Part of it's the hospital. A big chunk of it is the implant itself that goes in. That can be anywhere around about 1/3 of the cost, something in that range. Depends on how effective the hospitals are in managing that. But then there is the post-op, recovery phase, discharge. If there's a readmission, if there's some kind of complication, and the whole process starts over again, you can have a big spike at the end. So each of those comes with a different price. Different providers paying for that, or receiving that. And so if you say to the consumer, how much is this going to cost you? Or the consumer says, how much Well, how much is it going to cost me in hospital A versus hospital B, or Dr. X versus Dr. Y? Those are not really meaningful questions in healthcare at this point. At this point. So this is all, if we're going to have a consumer-driven system, we have to have, and get at these issues, we've got to have some big changes. That's what I want to talk with you about briefly and share my thoughts. Okay, so just first of all, I want to use a couple of languages. Reimbursement is the old word. Reimbursement, the concept of reimbursement is prices are set to cover costs. So the doctors and hospitals and medical device companies figure out, they decide what it is going to cost. You guys pay for it. You got to reimburse them for their costs. Purchasing, which is where I'm at, I believe you're at, is different. It says, no, costs don't determine prices, prices determine cost. The purchaser says, this is what I've got and what I'm willing and able to pay. You all in the medical system, you live within that. You give me a product for which I'm willing to pay. And the general trend in healthcare has been shifting from reimbursement to purchasing, and that brings us to prices, because prices really need to be a couple of things. They need to be transparent. The people who's buying it needs to know what it costs. Healthcare, if we make an analogy of healthcare, apparently this is a little bit before my time, but apparently back in the day, if you go out to a nice restaurant, there'd be two menus. They would hand, the gentleman would get the menu and have prices on it, and the lady would get the menu that had no prices on it. Well, that was obviously what's going on there, is that they wanted a price unconscious demand for dinner, and the way they like the best is just let the waiter decide for you. Because then, of course, they will. We're no longer in that, but in healthcare that remains. Okay? We still have menus without prices. Prices need to be bundled and coherent. We've got to be able to say, what is the price of a knee replacement surgery? Not what is the price of a physical therapy visit after it.
It's okay.
Or what is the price of the components, what's the price of each test. We need the bundle so that the patient can say, I want to go to this hospital or that hospital. We need this for maternity care. We need this for all kinds of services.
Spend our own. We're just more careful with our own money. And so we need to have this concept at the patient level that it's our money too. All right, so that's what I'm going to talk about. Okay. First of all, I'm going to do two things. I'm going to talk about transparency, bundle pricing, and reference pricing, and how they relate. And then I'm going to give you some of these data. I give an example because I do believe that reference pricing or reference-based benefits is a common thing in the employer community. The employers on the West Coast, the large self-insured employers, are finding this to be a quite effective way of influencing consumer behavior in a more cost-effective direction while maintaining access to services. Because what we don't want to do is reduce costs by having people not get care that's effective and cost-effective. That's not the goal. It's how to deal with this price issue. All right. Now, price transparency. It's the moment of price transparency in American healthcare. Okay, we all believe in it. We all believe that patients should make informed choices. Price transparency gives incentives for the physicians, the hospitals, the pharmaceutical companies, et cetera, Recipients of those prices know that they have to live within that. It's also the moment, because of the iPhone and everything that goes with it, we have technologies today that allow us to have prices be transparent, available to consumers at the time of the decision process. And it's what we all care about is the price to me. I don't really care about the average price of knee replacement surgery in the Pittsburgh area. I care about the price of this hospital versus that hospital, and also I care about the price to me. If I'm covered by the UPMC health plan, I care about what is that rate that they pay. If I'm not part of, let's say, the Highmark plan, I don't really, frankly, care about the Highmark rate. I care about my plan's rate, and then I care about what kind of, do I pay, have a co-insurance? Am I paying 20% of that? Where am I? That's what I care about. And now, in the wonders of technology, I can get that kind of information. So it's really so it's partly just a technology-fueled thing, and then of course it's also cultural. You know what I mean? We want everything to be transparent. Okay. It's coming, you know, Medicare is mandating certain kinds of transparency. Legislators are doing it. Employers are looking for it. I do believe that the technology is really the main thing because people don't care about average prices. They care about the price for themselves, and that's the relevant price. This is just some examples of there's a lot of companies out there now that can do this actually quite well. Okay? Now, the challenges to price transparency in this moment is that pricing in healthcare is incoherent. I think that and obscure and arcane and actually nuts, if I may use that kind of technical language. It's like when we go out and we want to buy a car, we want the price of the car. We don't want the price of the pieces of the car. I don't really want to know the price of the transmission or the price of the drive shaft or the price of the spark plugs. I don't know what to do with all that kind of information. And so making that transparent, putting that on a website, could you imagine if the car companies put on their websites the prices of all the components of the products that they sold, and that they call that price transparency? You'd say, that's insane. Well, guess what? That's how we do it in healthcare. There's states out there, including the great state of California, that mandate that hospitals put their charge masters on the website. Charge masters have tens of thousands of prices on them. What are you supposed to do with that? Okay. All right. There's certain parts of healthcare where a single price of a single component, okay. I mean, it's like, you know, what's an X-ray going to cost me? All right, okay, I can kind of get that. Or maybe what's a sort of routine pediatric office visit for my kid? Okay. But most of the stuff that really matters, no, I want the bundle. I want the bundle of all. If I'm going to go in for knee replacement surgery, to stick with that, I want it all in. I want the doctor in there. I want the anesthesiologist in there. Often they're not in there, by the way. You can go, oh, no, I got the price of the hospital, and then the anesthesiologist says, oh, no, I'm out of network. Here's my bill. Here's my bill. If you guys read the New York Times, they've had a delightful series of articles on this kind of a thing, of the incredible, bizarre stuff that goes on. It's like an only in healthcare kind of a situation. All right? And if it's only in healthcare, let's pause on that. Why is healthcare so different? Why is it so, if I make, you know, all of us, we all consume healthcare and we all bump into this stuff. And why is it so crazy? What, compared to the rest of the business sector or whatever? And you got to point your finger pretty quickly at insurance, okay? Because it is complex, it's inherently complex, but there's a lot of complexity in life, all right? There's a lot of complexity. And you have to point yourself at insurance, and then it's the structure of insurance, and then, well, who's responsible for the structure of insurance? Well, insurance companies, and behind them, their clients, which is the employer community. So these are the people that really need to think, okay, if we're going to make this the whole system rational, it really depends on us. And then, of course, we'll try to make a rational set of incentives, then hand it off to the physicians and the hospitals to actually implement it. But so I think, so this gets me from price transparency requires bundle payment where you have coherent pricing. Let me talk about that for a second. Fragmented payment, when we have different prices for every different component and going to every different provider, undermines the incentives for the physicians and the rest of the delivery system to collaborate and coordinate care. Because it really, you know, your typical doctor who's in private practice uses hospital services, but is not responsible for the cost of those hospital services. And so really, if you say to the doctor, what do you care about, is I want to get my patient in and out of there as fast as possible because I want to minimize the use of my time. Because if I'm a doctor, my asset is my time. Okay, that's really all I care about. I don't care about supplies. I don't care about staffing. I care about quality, but I don't really care about cost. It's the hospital's problem. And the doctors, the decision making. Think if engineers, at automobile companies thought like that. It would be great. We'd have a really expensive set of cars. All right? Consumers can't act with fragmented prices. We can't make good coherent decisions. Health plans are out there trying to develop centers of excellence relationships with particular hospitals and physician organizations to channel enrollees to providers that do a better job. And what does a better job mean if they can't get a single price on this thing? Medicare and some of the private insurers, including those I work with out in the West Coast, have experimenting with this. And what we've learned about bundle payment, it's a good idea, I'm in favor of it, is that it's hard work. And if all you do is bundle the payments, put the doctors and the hospitals together, give them a single price and encourage them to work together, they will begin to work more closely together. But then that might produce some efficiencies. It would produce some efficiencies. But those efficiencies, trust me, will not flow back to the purchaser. Okay? The hospitals and the doctors, they need money. They've got a lot of cool things they would like to do with money. So once they're working together, their idea is to let's work together, collaborate, and actually raise our prices. Okay? And we know that one of the challenges of physician-hospital integration is if there's no incentive, no market incentive for low prices, they'll choose the alternative, which is high prices. Okay? And high prices are very fun because there's no hospital that doesn't need more staff and more equipment. There's no surgeon that doesn't need more time, more staff, more help, more, a nicer vacation. All right, we all want that. So the bundle payment systems have lost some of their appeal to the purchaser community because they haven't come with a lower price. They haven't generated price competition among the hospitals and among the physicians that are receiving it. And the reason for that is, if I may say so, is that the hospitals that had the lower prices didn't get more patients. And the reason they didn't get more patients is that the benefit design, the insurance, didn't pass the savings on to the consumer. The consumer chooses where to go, chooses the doctor, and that's partly choosing the hospital. Most doctors are affiliated with a particular hospital. But if there's really no reason to compete on price if your consumer is not based on price. Is not choosing based on price. Okay? So that leads me to bundle payment, if it's going to work, needs some sort of benefit design, and I'm just going to talk about reference pricing. What is reference pricing? Under reference pricing, or really a better term would be reference-based benefit design. As you know, your standard managed care, health care in America system is the employers, all of you all, talk to the health plans, go out there, negotiate good prices with the doctors, the hospitals, and everybody else. And the health plans go out there and they do battle on your behalf with the delivery system. And they negotiate better rates than you could get as an individual consumer, But the reality is they end up with this huge variation in prices. That first slide I showed you about orthopedic surgery prices in California, those were not list prices, or if you're in the lingo, that's not the charge master kind of a price. Those are in the negotiated allowed charges between all those hospitals and the health plan that manages the product for the public employee system. That health plan is Anthem Blue Cross, and Anthem is not loved on the provider side of the healthcare system. It's kind of like Sherman's March to the Sea. That's the way that they kind of charge through the system, trying to beat down the doctors and hospitals. And then look what they ended up with. Unbelievable variation. When it comes down, I think that in the big struggle between the providers and the insurers, the providers are winning. Okay? They're consolidating, they're winning a lot. Okay? So what reference-based benefits is, it says, okay, we've got this incredible variation in prices, the kind of things that you read all those articles in the New York Times. We, as the employer, are going to say, okay, I will pay some rate, I will make a contribution towards that. I might pick the middle point. If the range of price goes from here to here, I'll pick the middle point. I'll pay that, up to that. And then the consumer, if the consumer gets to pick where to go, if you pick a provider that charges less than or equal to that, you're fully covered. If you pick one that charges more, that's fine. You just pay the difference yourself. Okay, it's your call. I will hopefully make this transparent what these prices are, but it's kind of like all of us travel a lot on business. Most of our employers have some sort of arrangement where the employer has a per diem rate. You can spend, I know, for the University of California, they use the government per diem rate. We'll reimburse you up to, I don't know, $65 a day when you're traveling for meals and incidentals. And you can go to any restaurant you want, Professor Robinson. We'll pay up to $65. And I, of course, say, oh, no, but my health and quality requires that I go to the 4-star, Michelin restaurant. And the University of California, which is a completely bloodless entity, says, that's great, $65. Right? And so, whatever. And so I make my, at the margin, it's my dollar. And sometimes I spend some of my money. Sometimes I don't. Right? That's the way I do it. And so that is the basic concept. And and I'm going to talk a little bit more about that because I do work a lot on reference-based benefits. But we have to say that reference pricing or reference-based benefits has some problems. First of all, the consumer needs to know what the prices are. And most people don't know and can't know. There's just simply no way. There was an article in the New York Times. There was this great little study. They called around, what is the price to hospitals, a bunch of hospitals, of hip replacement surgery? That's a fairly standardized procedure. It's not like, what's the cost of treating metastatic melanoma? Okay? This is fairly discreet. And they couldn't get any hospital to actually tell them what is the price. The only price that they could get out of the hospitals is, what does it cost to park at the hospital while you're getting your procedure? That price they could get. Okay? All right. And then consumers need price data, and they also, of course, need quality data. Because all of us, when we say what's something going to cost, we also want to know, we make that trade-off. Back to my little restaurant analogy, I do care about the quality of the food as well as the price, and I make a trade-off. And we do that. People are actually humans. Depending on the day, I think humans are either really smart or really dumb, okay? But generally, we have to say we are capable of making very complicated decisions. Sometimes people say, no, healthcare is too complicated for people, can't make the decisions, it's too complex. Leave it to the doctors. But the reality is we all make very complex decisions in our lives, one way or another. We all decide what career to pursue. That is a very complicated decision. If you think about the implications of that, and how many, we all decide whether to get married, and if so, to whom. That's a complicated decision. Back in the day, a couple of 100 years ago, everyone thought that decision is too complicated for people to make on their own. Nobody thought that young people should be able to pick who they're going to marry, right? That was just obviously a stupid idea. The parents and the tribe were going to pick. And the young people kind of, made it work. Right? That's the way it was. Right? Now we all believe people should, marry for love and that kind of stuff. And I don't know. The evidence is still unclear as to whether that's the right approach. Right? All right. Okay. So reference pricing needs price and quality transparency. So let's be summarized. Where's the argument today to this point? Price transparency, to make sense, needs bundle pricing. But bundle pricing needs reference pricing so the consumers care if it's going to work. Reference pricing isn't going to work unless you have price transparency. So this whole thing is circular in the good sense. I would call it not circular, but maybe, synergistic or whatever the right word is, that we need all three of these. Okay? And out there in policy land right now, the sexiest thing is price transparency. Okay? Because Americans think that giving people information is a solution to all problems. All right? This is obviously wrong. Nevertheless, it's part of our culture, and you know, we believe in transparency. We put everything we have. We were very concerned about privacy. On the other hand, we put everything on Facebook, and that's just the way we are. Bundle pricing is very popular in policy wonk land. People like me, who are professors and work in think tanks and hang around in Washington, D.C., work for the administration or work for the non-administration, believe that the solution is to change the way doctors and hospitals get paid. That's the basic solution in healthcare. And I think that there's some good truth to that. But I personally think that where the action is right now is on the benefit design issue. We are moving, the consumers need to be engaged. They've got to care. We've got to have an informed and engaged consumer, and that part of that is they've got to be understand that some of this money going into healthcare is their money. Otherwise, there's no way you're going to have a value-based healthcare system if the consumer doesn't care about the cost side. If the consumer's only talking about convenience and quality, you're going to have a very convenient, very high quality, very high cost healthcare system. That's what you're going to get. Okay? All right, so now I want to talk a little bit more about reference pricing, and then we'll wrap up with it because you've got some excellent speakers after me. Okay, so reference-based pricing, as I described, has been applied to a variety of things, drugs and lab tests, imaging, and procedures, particularly non-emergency scheduled procedures like joint replacement, the kind of procedures that Tony does, arthroscopy, colonoscopy, et cetera. And I have worked with a number of both public and private employers. I'm a professor, I do research on the effects of these, and I just want to give you a few examples. CalPERS, California Public Employee Retirement System, as I said, covers about 1.3 million patients. They have some HMO products and they have PPO products. This is all about PPO. They started out, that little graph was their data, pre-reference pricing, incredible range in prices from $20,000 to $120,000. What are we going to do about this? They said, okay, they looked at that. First of all, I guess they created a data warehouse so they could even see it. Before that, they didn't even know what they were paying, frankly. Yeah, they didn't know. But anyway, they picked the number $30,000. $30,000, there was about 50 hospitals in the state of California that charged 30 or less on average and were geographically distributed reasonably well and passed the basic quality metrics. We don't have great quality metrics on orthosurgery, but there's the Blue Cross Blue Shield Association has its metrics and whatever. And so they identified these as they gave them the term high value system. And so then they let it roll. They implemented it, and this is what happened. This is for a study. The red lines are the CalPERS members, and the blue lines we had just a control group of these are enrollees in Anthem Blue Cross who also got joint replacement, but were not subject to reference-based benefit. So over time, this 5-year period, to see the blue lines, basically nothing happens. If they're not subject, there's no change in their benefit design, no change in where they go. This is the percentage of patients that go to the value-based purchasing. Basically means that low cost. Let's just put it that way. All right. And so what you just see is a big change in market share. I don't want to make overdos, but people do vote with their feet when they're paying with their money. Okay, because what they do is they know that these hospitals, it's less than 30,000. Those it's more, and they move with that. What happened? How did the hospitals respond? These, once again, the blue lines are Anthem. Prices just generally are drifting up. This is healthcare, right? The red lines are the CalPERS members. The CalPERS members, this is the prices charged over time in the low-priced hospitals. You see it just kind of keeps on just being more steady. The high-priced hospitals, when we implemented reference pricing, boom, did those prices come down. Okay? The hospitals, they want these patients. Remember, if you're a hospital, you've got a number of different kinds of patients financially. You've got Medicare patients. Medicare pays you kind of like it's a thin soup. You can live on Medicare, but you're not happy on Medicare. You're like dieting. You're on a diet, okay? You've got Medicaid patients where Medicaid, I don't know about in Pennsylvania, but in California, Medicaid, you lose money on every single one of those Medicaid patients. I mean, there's just no question you're doing it because it's the right thing to do and whatever, but you're not making money on that. Then you've got uninsured patients. You're making even less money on them. And then you've got the self-insured employers, and that's where you're making your margin. Okay, that's where you're really doing it. And now we've set this thing up so that those patients are moving away from your hospital. Okay, they're going to some other hospital because of this. And the hospitals, they respond to this. Okay, this is what we call price competition. A totally new concept in healthcare, and never seen before, first in man, as we say in the pharmaceutical industry. Okay, all right. Another example, ambulatory procedures. PERS expanded from the inpatient orthosurgery to ambulatory procedures. What they have experienced as many markets in the country, as more and more procedures, they go from inpatient to outpatient. There's always a choice between the hospitals have their outpatient surgery and diagnostic clinics and departments, but there's also freestanding, non-hospital based, and it just turns out that the freestanding ones, they're not carrying a lot of hospital overhead, and God bless the hospitals, they're doing a lot of great things, but they do have a lot of overhead, which they then lay onto these ambulatory procedures. So this is what CalPERS was looking at. These, once again, each one of these dots, if you will, is a facility. It's the average price charged by a particular facility. We just rank them from the cheapest to the most expensive. The first thing you see is, oh my God, is there a variation out there? This is colonoscopy. Okay, once again, pretty routine screening colonoscopy, pretty routine procedure. There's not a, don't give me a whole story about case mix variability or whatever, I don't know. I think probably some of the people in this room have actually experienced a colonoscopy or whatever. I mean, it's whatever. We're going to get in there, do this, and get back out of there. Okay, this is not that complicated, all right? And, but look at what they're charging. And these are negotiated rates. These aren't like, this is the hospital, I mean, the surgery center of the hospital says, this is what I want. This is what Anthem Blue Cross has actually signed a contract to pay. Okay? So they look at that, and then, so first of all, there's a variation, and then there's the difference between the red dots and the blue dots. The red dots are the freestanding ambulatory surgery centers, and the blue dots are the hospitals. Okay, this is California. There's a lot of facilities. California, big state, lots of hospitals, lots of surgery centers. And so you look at that. So they just said, okay, we're just going to, they stared at that. And they said $1,500. You see, and so that black line is at $1,500. That's the CalPERS rate. We shall pay up to $1,500, and you, the patient, can go wherever you want. Okay, we're not going to get into the whole the big choice in healthcare is to try to manage prices. Do you want to have narrow networks and restrict the patient's choice to a subset of the providers, and then that subset offers you a price discount in order to get higher volume? So that's strategy A, and that can work very effectively. Strategy B is, no, preserve patient choice to the extent possible. Patients can go kind of more or less where they want to go, but limit how much you'll pay so that if they go to the most expensive place, they pay more out of pocket, and that encourages the most expensive providers or most expensive pharmaceutical company, whatever it is, to moderate their price. I mean, those are your two basic choices. All right? This one, we're all talking about the option B here, strategy B. That's what we're talking about today. Okay. Anyway, they put that in, and what happened? First thing is, once again, the CalPERS people are red, and the control group is blue. First thing, this is the percentage of people that get their colonoscopy in a freestanding center, and you just see that prior to reference-based pricing, not much was happening. For Anthem people, not much is happening, and they're just slight drift up. But oh my God, the CalPERS people start to move. Okay, because they're saying this, and by the way, I work in healthcare economics, and I've been around a long time. I've studied a lot of different incentives to try to influence behavior by employers and insurers, influence behavior in healthcare. How do you pay doctors? How do you pay hospitals? How do you do this? How do you do that? Electronic health records, capitation, shared savings, care management, disease management, wellness, you know what? And the healthcare system is like the inertia rate in healthcare. Nothing changes in healthcare. It just kind of grinds on, right? We try this, we try that. It just kind of like, you know, the straightest line out there is the line of healthcare cost inflation. It just kind of goes like that, you know? You just can just predict it. It's like, you know. And, but you put in reference pricing and things change. I mean, in year one, things change, okay? What about pricing? Look at this. Okay, this is what they're paying, okay? So this is like calculus. Oh, I kind of like that. See that negative slope? This is like price going down. First in man. Right? First in healthcare, price going down. Okay. What about, we also looked at, you know, complications, and because obviously you don't say, okay, wait a minute, we don't want to channel people to low quality providers or whatever. So anyway, this is rate of surgical complications. Colonoscopy, safe procedure. There's not a lot of complications out there. They're sort of in this 1 to 3% range, different kinds of complications, and you know, we could talk about that. I'm not a physician, but we had a physician working with us on this. But anyway, the long and the short of it is no change, okay? So it's not as if those gains came at the cost of lower quality. That's the only point I'm trying to make here, okay? Now, the point of colonoscopy is not to have a safe procedure. The point of colonoscopy is to accurately identify, you know, colon cancer or other conditions. That's really what you're, you know, why you're doing it. And the kind of data we have don't, you know, don't show that. And the main issue on colonoscopy is who should be getting one of these things and who shouldn't. There's a whole issue about if you follow this stuff. But that's not what we're about here. Those are very important issues. Those relate to the appropriateness of different kinds of treatment. In this case, different kinds of diagnostic and screening treatment. By the way, but just in case you have any doubts about colonoscopy, colonoscopy is on the list of essential health benefits under Affordable Care Act. Employers and insurers have to offer screening colonoscopy at zero copay, right? Prevention, cancer preventive screening. Turns out that this has been heavily reviewed and heavily debated, that reference pricing is considered legal under that, even for these cancer screening procedures, because the patient can get the procedure at a zero copay if they go to one of the lower cost providers. And you have to set the reference price so that there's enough lower cost providers for which it's zero copay to the patient. From a CalPERS perspective, we want to do that anyway. You don't have to force us to do that. We want to do that anyway. But they look at the geographical distribution. And they also have exemptions. For a patient can go to a high-cost, hospital-based center without copay if either their physician has a clinical reason why this patient needs to go there. Special case, complex case, comorbidities, whatever the story, you know what I mean? But it's got to be a story. I mean, there's got to be a story there. Okay? And they generally, CalPERS generally is like, okay, if a doctor's arguing for this, we're going to kind of go say yes. We're not going to, you know, get in there. The other one is if the patient's living in some rural area in California where they're not that close to a cheaper area. I mean, there's some rural areas in California where they're just, you know, the only thing out there is a hospital. And a hospital in a remote area is a high-priced hospital. Trust me. Okay? All right? Because there's no competition out there. And so CalPERS just throws in the sponge and just says, okay, we're going to pay that. You know, increasingly, they're going to want to do something different. Maybe not colonoscopy, but increasingly they're going to say, well, if you travel a little further, we'll give you a benefit. Okay? I mean, the travel medicine is coming. Okay? It doesn't have to be something exotic like Singapore. Okay? It can be something like, you know, would you drive, you know, 50 miles for your procedure? Patients say, 50 miles? I can't drive 50 miles. You know, and then you ask them, well, how far do you drive to work? Oh, well, 45. Okay. So that's common. It's also common at the more high end in regional centers of excellence, and that I'm sure the UPMC is interested in this, but there's a lot of employers are saying we're sending all of our orthosurgery patients, or we'll create incentives for all of our orthosurgery patients to go to one of 4 hospitals, regional hospitals, or for interventional cardiology, we'll try to send them all to the Cleveland Clinic or something like that. Why? Because quality is good at the Cleveland Clinic, of course, and just let me guess, they've got a nice low bundled price on the deal. Okay, because if you're in Cleveland, you kind of say, what's my local market growth? In Cleveland? I mean, I don't know. I don't spend a lot of time in Cleveland. But it's not like a go-go demographic area to my knowledge. Okay? So if your question is, well, what's your price to get a patient flown in from Los Angeles to Cleveland in the Cleveland Clinic? And I'm just guessing. Be like, oh. Okay, I can probably come up with a really affordable bundled price on that. Okay, so employers they're looking at that. They're looking at that. And you don't have to send everything to Cleveland or to Hopkins or to UPMC. You just, if you're the employer, you just send the high margin cases. Okay, because healthcare, like many other businesses, they lose money on a lot of patients. They make money on a few types of patients. Those patients, you move those patients, you got the hospital's attention. Orthopedic surgery is one of those. Interventional cardiology, diagnostic radiology. This is where the hospitals make their money. They lose their money, on all those medical procedures and pneumonia and psychiatry and burn and kids and all that kind of stuff. That's all God's work type stuff. Okay, this is where the money is. Yeah. Okay, so the U.S. So what are the implications of all this? The U.S. healthcare system, love it or less so, is continuing to shift responsibility onto the consumer. I think that the employer community, and with them the health plan industry, has really tried to, improve the efficiency of the healthcare system, the value, whatever. That was called managed care, and without bringing the consumer along. With the consumer, if you go back 20 years to 15 years, high point of managed care, the basic deal was the buyer is going to put the providers on capitation and lots of incentives for the doctors and hospitals. The consumer will experience all of this. You can get anything you want for a $10 copay. All right? So the consumer's attitude is, first of all, believes healthcare is worth $10. That's what the consumer believes. And then also, the consumer bumps into managed care in terms of the doctors complaining about it. No, you can't go to this specialist. We're discharging you early from the hospital. We're switching you from drug A to drug B. And the patient's going, wait a minute, you promised me I could have anything I wanted for $10. And that got the backlash going. Oh, this managed care stuff is saving money for the employer, for the insurer, maybe for the government, but not for me. And they didn't like that. And in the end of the day, politically, the consumer wins. The consumer wins, okay, because consumers vote. Politicians are onto that. Consumers have lawyers, okay, et cetera. So the world is, we got to shift more responsibility onto the consumer, and I believe in that, but I think we all do. But it has to be an informed and responsible system, okay? So I want to then wrap this up, and then I'm more than open to any comments and questions and discussion, because really all of us, nobody has a monopoly on truth and wisdom here. We're all kind of groping our way what works and what should work. I just want to summarize again on my 3 points on price transparency, bundle pricing, and reference pricing. Price transparency is a good thing, but it's not the solution to the problems of the healthcare system. All right? It does support patients, allowing them to be better shoppers in healthcare. We all need price information to make reasonable choices in healthcare. We need that. And it's also consistent with our larger culture. It's not just a sort of a utilitarian thing, but it's a philosophical thing that we're making responsible choices. Responsible choices require good information at the time of care, valid, et cetera. okay? But if the price transparency is to be meaningful, it has to be, the unit of observation, if you will, has to be meaningful. We have to have some sort of bundled pricing so the consumer can really compare card A to card B, not transmission parts and spark plugs. That doesn't work. And also mean we need to have some sort of benefit design so the consumer cares, okay? Because if you say to me, Jamie, I could tell you now what the price is, and it's all nicely bundled and everything, of all the hotels in the Pittsburgh, but your employer is paying for your hotel bill. I'll be like, you know, I got other things to do with my time than pay attention to your hotel prices, right? I just don't care, frankly. I mean, you know, so people need to care. Secondly, bundle pricing. Bundle pricing is a good thing. It is a good thing. And all the policy wonks, it's a big part of the Affordable Care Act, et cetera. It's a good thing. It gives incentives to doctors and hospitals to think that they live within a unified budget, makes them think that if we save money here, the basic point of bundle pricing is, doctor, you're making the decisions. If you make decisions such that you reduce the cost of care, some part of that comes back to you, either directly, some sort of financial gain sharing, or indirectly, there'll be more resources for your practice, for your, the hospital, et cetera. You will benefit, and just like the rest of us, doctors, you know, it's just amazing, by the way. You give them this kind of a gain sharing, and doctors change their behavior. They just do. Okay? It's just like consumers. You give consumer a financial cost sharing benefit, they change their behavior. They just do. Okay? This is healthcare. People behave in healthcare more or less like they behave outside of healthcare if the incentives are structured that way. If they, you know, we used to be in the world of health policies was, oh no, there's most of the world kind of runs by these kinds of rules, supply and demand and all that kind of stuff. And then we have healthcare, and it's over here, and it's special, and it's different. Okay? And there's some different parts of healthcare. It's unique, it's wonderful, and it's complex, and it's crazy. But the main thing is that we haven't put these kind of incentives into this kind of a system. And when we do, oh my God, it works. Right? And bundle pricing is also good for payers that want to compare and negotiate with prices. But it requires reference pricing or something like that, some sort of incentive, because the consumer, once again, doesn't care about the bundle price if they're not paying part of it themselves. And of course, it requires some kind of transparency, because if the patients don't know what it costs, I mean, I would even just say, you know, we could just even do a show of hands. What's the range of prices in the Pittsburgh area for something really basic? Okay, and you guys have some interest in healthcare. You're here today. All right, MRI of the brain. What's the price? Pittsburgh hospitals. Okay. No, probably no one's got a really good idea. What's the price? What does Tony charge for knee replacement? Okay. What's the range of knee replacement prices? And of course, then that's just the surgeon. Probably Tony knows. What does Tony know? He probably knows his price. He's the surgeon. He gets a fee schedule. He gets a fee tip. He's probably got a fee schedule, and he gets paid almost nothing by the insurance company. You ask him, they don't pay me anything anymore. But then there's the anesthesia, and then there's everybody else. All right? So we don't know. We don't know. We need to know. And then thirdly, reference pricing. We spent a lot of time on that today. It's a good thing. Some form of, we need to convert patients into shoppers. By the way, where reference pricing actually came from in the States, I think the first company that did it was, that pioneered it was Safeway. Safeway's a grocery store chain. I don't know if they're in the Pittsburgh area. Big in the West Coast and some other parts of the country. And their customer base will drive across town to save $7 on some product. They clip coupons, you know, they're really, I mean, Americans are just going to shop. And their employees, though, they saw themselves, they were paying for colonoscopies, actually the one they started looking at, they were paying, even in the same market, between $700 and $7,000 for the same procedure. And these are all in licensed accredited, board-certified, places. And the patients were going, well, why are you going to the $7,000 place? Oh, well, the usual explanations. My cousin went there, or it's down the block, or, whatever. And you can't get them. You say, well, why don't you go to one of these cheaper ones? Oh, no, I'm not going to do that. But I will drive across town to save $7 on, a package of multiple shampoos, right? And so then they put in reference price and say, okay, we're going to plug this in, okay? So, but we need price transparency and bundle pricing. And so I just want to wrap this thing up. Just bring it right back to what my book is about this. It's about purchasing, focus on innovation. We, the economists, strongly believe that what drives healthcare cost over time is new drugs, new procedures, new tests, new implants, all of that stuff. That's great, but it's expensive and it would cost. And if we want to have value on it, it really is about getting more sophisticated in the purchasing of this stuff. We have a very sophisticated and wonderful supply side of the market for innovation. Drug companies, device companies, diagnostics, genomics, imaging companies. It's great. It's wonderful. It's a great industry. Great products. We have an underdeveloped buy side of the market. The buy side of the market is the employers, the insurers, and the consumers. They've been outplayed by the industry. Need to get more sophisticated about the science, and then plug this stuff in the way that we pay for healthcare. So that's my message to you, and once again, very much appreciate being invited and look forward to spending the rest of the morning with you all. So Tony, thank you.
So thanks, Jamie. Thank you very much. We do have lots of time for questions for Jamie. So we have folks with mics. If you just raise your hand, and when you ask a question, if you could just introduce yourself and also what role you play in your organization as well. So we start here.
Thanks for that great talk. My name is Roy George. I'm from marketing in a medical device manufacturer. Question is, what was the fiscal impact of the program by CalPERS on the colonoscopies? So since implementation, what kind of return have you seen on that?
What CalPERS itself, in the first 2 years post-implementation, it saved them $7 million on this one procedure. That's money they can taste. So they are keen on this. I'm not saying that you can bring down the price of colonoscopy all the way down to zero, right? I mean, this is not going to continue forever, but it's certainly, there's real short-term savings, and so this is something that the employers can taste. That's the point I'm trying to make. Whereas a lot of the programs that we put in, you kind of put in a good program, disease management or whatever, and you just kind of say, did that save me anything? Can I measure that? And with this stuff, you can measure it.
Hello, I'm Mike Cassidy. I'm a local healthcare lawyer, so I advise various people on healthcare issues in my organization. But my question is, do you have any economic evidence with respect to the actual price point that influences behavior? Because reference pricing isn't really a new concept. Copay is the same thing. It just wasn't enough. High deductible plans, it was too draconian. The results were that people would not buy any health care because they didn't want to spend any money. So how much does it take in health care to make them change their mind?
Okay. So the question is, is there a tipping point? And of course, that's probably going to vary for different kinds of procedures and different kinds of people. What's different about reference pricing compared to the copay, for example, or compared to even a deductible is that deductible works like this. You're the consumer. You pay up to, let's say, $1,000 a year, or whatever your deductible is, and after that, the insurance company starts paying. Right? Reference pricing is the exact opposite. The insurance company or the employer pays up to the reference price limit, let's say it's $1,000, and after that, you, the consumer, pay the rest. Sounds just kind of like a minor. It's fundamental. It's fundamental, because that means that the marginal dollar is paid by the consumer rather than by the employer, and it's the consumer making the choice. Okay, so the short answer is to your question, what's the tipping point? At least under reference pricing, You can pick your reference price. You look at the range of prices, and you just pick the median, or if you want to be, depends on it's a choice. You could pick the 80th percentile, which means that 80% of providers are fully covered and 20% are above the reference price, and you'll see some market move. You could pick the median, you could pick the 40th percentile, right? You could pick different places.
Yeah, but I don't know, it's the opposite. I mean, it's just a much more expensive copay. You know, $10 is not enough to influence anybody, but if you have to pay the difference and the difference is $500, now you're paying attention.
Well, reference pricing, so partly it's the size of it, but I actually think it's it's really different because reference pricing has also been applied to lab tests, including like $5 lab tests, like blood tests, and to drugs. Okay, and it's had dramatic effects on that too. It's just like those Safeway employees that'll drive across town to save their $7. People will move they will move from the brand to the generic, and it's not that much money. It can be to save a fairly small amount of money, but if it's a high volume repeat thing, people will change their behavior. And of course, not everybody has to change their behavior. All you need, from the provider point of view, to get them to be cost conscious is to have some of their customers walk away. And they move. That's what we care. Just like in any other business, not everybody has to move. Some people have to move. So I think that it's a trial and error thing, to answer your question. I do believe that the consumer is what I would call the cheapest date in healthcare. When they're spending their own money, oh my God, will they move? Doctors hate this, by the way. They think they've got this long-term personal relationship with the patient, and there's all this trust and all this kind of stuff. And then the employer changes the benefit thing, and the doctor's now in tier 2 or whatever, and the visit copay goes from $10 to $50, and those patients are like, they're out of there. Right, Tony? But not all of them, but just some of them. Anyway, I don't know if that answers your question, sir, but I think it's a trial and error thing, but it does seem to work. That's main.
Hey, I'm Eileen Anderson. I'm the Director of Government Relations at SMC Business Councils, and my behavior has been changed. I've had a high deductible plan since 1997, and oddly enough, we have been shopping for a colonoscopy in Pittsburgh for my husband. And I just want to tell you, I understand what you're saying about the reference pricing, but the practical problems that you hit at the ground level where the war is with price transparency are almost insurmountable. You can call a doctor's office and they will give you codes, and then you can go to the insurer's website. There'll be 10 choices for a colonoscopy, and there'll be no codes used. So I think we spent probably more than 3 hours on the phone trying to figure out if this was a preventive colonoscopy covered under the Affordable Care Act or not. They said it was. We got the explanation of benefits. They said it wasn't. And ironically, there are no codes on the explanation of benefits. That seems to be a trend with insurers or whoever is doing those. They take the codes off so you can't go back and actually find the price. So I find that while shopping has gotten somewhat easier since 5 years ago when I shopped for a mammogram, it's still very difficult because the tools, while they look like they're there, they're actually very confusing, maybe intentionally, and the codes are disappearing. So I think there's a real problem on the ground level. And the price was bundled. There was a doctor's price. There was a facility price. We did all the searching. There was a lab price. Didn't know about the anesthesia. But what you look for and what you get are two very different things. And I think that's where employers have to go after insurers and say, you get those prices on the website and you use codes because the tools are going away.
Well, I'm taking you along when I give these talks in the future because it's just perfect. See, transparency per se just gives you confusion. We need coherent bundled pricing. And then, of course, you started paying attention to this because you had a deductible, then this fell under the deductible and it was your money. Back in the good old days, if you didn't have a deductible, you would say, yeah, it's crazy, but it's somebody else's craziness, right? I don't have to get involved in it.
Hi, I'm Jan Klein. I'm the chair of a consortium for healthcare for Allegheny County school employees. We're huge. And the battle that we fight, not only what you're doing, which we believe in and think that we need to move towards that direction, but the battle we fight is infusing the information about quality. Because the relationship between quality and cost isn't always there. In fact, I'm not sure that there's any direct tie between quality and cost. Having said that, are you looking into, are there quality benchmarks out there that you believe are believable and usable and transparent enough for us to use?
Okay, so the question is, well, obviously we care about the quality and all of this, and how good are the data on quality? And the answer, I believe, also is it's a glass half full, glass half empty. The quality data are much better than they were a few years ago, but they fall short in a lot of ways. And the physicians will tell you very truthfully that a lot of the things that are being measured are not the most important things. They are the things that are measurable, and which the response needs to be some version of, well, so what? We kind of measure what we can measure and we make progress, and we also need to use the metrics that we have, because quality data doesn't improve unless it's used. If it's not used, it can just sit on the shelf. People don't even know whether it's good or bad. When you start using it, you start finding the problems, then you start improving it, and we get in a cycle. It's also a cultural phenomenon of, most patients' concept of quality is my doctor. That's quality. And whatever my doctor says, that's quality. And that's the problem when you start, if you're an employer, you're an insurer, and you start messing with that, you can get in trouble very quickly with the workforce or with the others. That's actually how Safeway got into it. They thought, there's a lot, if you look out there in healthcare, they see all these costs that they don't think are necessary. Some of it is inappropriate utilization. But for them to go in there and say to the worker, your doctor says you need that test, but that test is not appropriate, you don't need it, we won't pay for it. Whoa. Employees don't like that. My doctor said I need that test. So Safeway's thing was, okay, you want that test, you can have that test. Where are you going to get that test? Well, here's the range of prices, and bang, we're going to have you're going to shop the price of this test. And the consumer's like, oh, I know how to shop price. I do that every single day of my life. I could tell you the price of gasoline all over town. I'll drive half a mile to save 5 cents on the price of a gallon of gas. Everybody does that, by the way. Everybody pays attention to gas prices, okay? And so this is part of that. So I think that the quality thing is a long journey. It's a long journey. Appropriateness is a long journey as well. I think that the interesting thing about price is it's a shorter journey. It's easier to have short-term wins from a cost savings perspective dealing with high prices than to deal with some of these complex quality and appropriateness things, which are important, but they're more complicated, and it's a longer lunch. Let's put it that way.
Good morning. My name is Rich Godowski. I'm the medical director for commercial products for UPMC Health Plan. My question relates to reference pricing in the economic discussion around mandated preventive services. And so in the U.S., organizations like FDA, USPSTF never consider cost in their recommendations. So if we used your argument around value-based pricing for colorectal cancer screening, for instance, the reference-based price would be around $30, and consumers would choose fit testing over colonoscopy every time. But those agencies never consider cost. So how does consumer choices and cost transparency play into preventive services, and then that we are mandated to cover at no copay under the Affordable Care Act?
Okay, so the question there is that under Affordable Care Act, health plans are not allowed to charge any kind of cost sharing for a defined list of preventive screening and other interventions, and a number of those interventions, the clinical value of those is debatable. I think that's a fair statement. In the colonoscopy, there's a variety of ways of testing for screening for colon cancer, and they have different price tags. And the clinical dimensions of that is They're somewhat equivalent. And it goes to mammography, PSA, whatever the test is, it's controversial, right? So, yet they're mandated. And now reference pricing is an end run around that in one particular way, in that it's you can chop off the upper end of the tail on these colonoscopy or other types of things, other kinds of imaging, et cetera, okay, mammography, et cetera, so long as it's free at a number of units. Just a general issue, if I may take a little slight digression, why do we have mandates, coverage mandates for zero copay for preventive screening procedures? Where'd that come from? I think those kind of mandates, it came from unintelligent consumer cost-sharing designs. That this headlong rush into high deductible everything caused a backlash. And just like we had a backlash against managed care, we're getting a backlash against consumer-driven healthcare. If you interpret that as high deductible health plans. Because high deductible says everything up to $1,000, $2,000, $5,000, what is your deductible? What are we talking about here? Is out of your pocket, consumer. And the consumers, like I say, sometimes they're very smart and sometimes they're less so. There's a lot of evidence that people are not taking the drugs that they should be taking. They're not getting tests that they should be taking. There were serious problems of adherence and compliance going on out there. And it's aggravated by some of these cost-sharing designs. So there's a backlash saying, no, you can't put that on. And so that's why I think we need intelligent cost-sharing. I've been talking to you today about reference-based benefits. I think in certain contexts, I would call that falls into the intelligent benefit design category. It's not a panacea. That's not a solution to everything, and there's other things, and we can talk about that, and that's for you all. You're the experts to figure this out. But the cost-sharing is essential. But if it's not done in a way that separates the wheat from the chaff, the wheat of the cost, the effective treatment from the ineffective treatment, we will get mandates. Just like you've got mandates on any willing provider and mandates on length of stay and mastectomy and all of that, you'll get mandates. It starts with prevention because that's God's work, right? Everybody believes prevention. But then they're just going to go right through it. You're mandated to cover all drugs, within certain therapeutic classifications. Then you can be mandated, exempt from cost sharing. You're exempt from cost sharing. Essential providers. Who's an essential provider? Tony's an essential provider. Everybody's an essential provider. It can just go like that. So I think that there is a balancing thing here culturally and politically in the design of health benefits. And you want to pick the low-hanging fruit, which will have short-term as well as longer-term impacts, but also stuff that's culturally compatible with the American psyche. And I do believe that reference-based benefits, because it addresses price variation, not appropriateness variation, is more compatible in the short term. And if we can get Americans thinking that there's price variation and it matters in healthcare, that will help us get along to the point where we can help the consumer believe that there are appropriateness variations and we have to deal with that. That's sort of a path. That's my perspective.
How about Mike has one more question?
Hi, Jamie. Mike Parkinson, UPMC Health Plan. What was an unintended consequence of the CalPERS Safeway experiments, things that you didn't predict? You don't predict from an economist standpoint. You'd see people being sensitive. But what are the things people should watch for, either for the good or for the ill, unintended consequences that surprised even the initiators?
Well, I'm not sure about unintended consequences, but if I may slightly how did the industry respond to this? How is the industry responding to this? Now, of course, what the employers want is that the industry to do price competition. That's the goal, and that you certainly see some of that. On the other hand, the industry is also there's a couple of different ways of fighting this. One is to make the prices even more arcane and non-transparent than before. That's one issue. Another is further consolidation and have contract clauses which prevent let's say, you know, multi-hospital system of the type we've got in every city in America, you know, if we have variation in prices across our facilities, you can't do reference pricing on us. We're all or none, that kind of a thing. You see that out there. You can go to the legislature and mandate that you can blow this out through mandates, basically. You can say that it's got to cover all, and et cetera. So, you know, this is a chess game. Every move, there's a counter move. And also, I think that with reference pricing or anything else, we have to be realistic. There's a certain amount of there, I think. There's certain benefits to the employer. But it's not infinite. And then you can't save the same dollar twice, as we say. You'll move on to the next thing. So I think it's all part of a strategy, but it's all part of it, and I may wrap up on this, of becoming better purchasers of healthcare. That's really what it is. This is just, the answer is not reference pricing. The answer is sophisticated purchasing of healthcare. That's what will get us the healthcare system we want. And with that, I think I'll turn it back to Tony and say thank you very much.
Well, we'd like to thank Jamie again for starting up Commerce the way we like.